Welcome back and thank you for staying with Newsline. Now, it's been a month since the government rolled out the Social Health Authority, and several patients across the country claim that accessing healthcare has become a nightmare, while others claim they were forced to pay out of pocket for services that were previously covered by the defunct National Health Insurance Fund. And that's what we want to dive into, the transition to the Social Health Authority, and especially for referral hospitals. Joining me for this conversation is Dr. Philip Kirwa, who is the CEO of the Moi Teaching and Referral Hospital. Good evening, Dr. And thank you so much for joining us. And now, before we get into this conversation, earlier on, we had asked you on our big queue to share your concerns and experiences in regards to that Social Health Insurance Authority and the Social Health Insurance Fund in general in the implementation. Of course, you can use 22151, which is our SMS line, or you can use X at KTN News KE, at Ashley Mazuri, at the Jesse Rogers, and we'll continue sampling some of your issues. And Dr. maybe we can start from there, because I have some of the responses from Kenyans. And here one is saying, I have registered my membership to SHA up to 60%, and I'm not able to continue because I cannot access biometrics. Where can I access it?
Yeah, so thank you very much for having me here tonight.
Karibu.
It's a pleasure talking about SHA. SHA is a major game changer for us in the health sector, knowing that we've suffered a lot as Kenyans and also as healthcare workers and managers in the health space due to the challenges of our people not being able to access healthcare because they're not able to pay for it. Now, with SHA, which is an equalizer, that's why it's called a universal, or UHC. It's the universality of ensuring everybody's covered. And therefore, we've had a few of the hiccups, just like anything else that comes in when it's new. You will have hiccups, you'll have challenges here and there, and we are up to the task to have the solutions for that. So for a person who has registered, paid for SHA, and are not able to access service because of the biometrics, there are two options. The first option is that they can still use an OTP on the provided through the service providers. But the second option is that they can actually walk down to the SHA offices, any SHA offices, wherever they stay, and they will get their biometrics sorted out.
Okay.
And that will actually open for them the ability and the possibility of getting whatever they need from the healthcare space.
All right, so let's now go to the referral hospital. How is SHA working for referral hospitals?
Yeah, so thank you. So for referral hospitals, of course, we began on the 1st of October. So we've had approximately 35 days of experience with SHA. So I could say that from the first day, we, of course, had a major challenge with the network and the related ICT infrastructure, which was partially not working. And a lot of people also, among even ourselves, we did not understand how to handle those patients. But having had a quick crisis meeting again, championed by the Ministry of Health, we were able to see all patients from day one, and that nobody was sent away without service. And all the patients who had registered with SHA, as long as they had evidence that with NHIF, they had evidence and were already in the system in the process of getting treatment. For example, I would say dialysis, oncology, those were already pre-planned for elective surgery. All of them received their services. The only difference is that we were not able to upload the documents, and we just noted the documents and also kept records of the patients, which we did later when the system was up and running. So
apart from systematic challenges, were there any other challenges that you witnessed?
Of course, a lot of it is in misinformation from both also healthcare workers, just the public, and even the patients. Is that when a patient comes in and they are not registered, for example, for NHIF previously, the advice is that register for SHA. And when you register for SHA, it means you're going to go through the whole process, including the mean testing. And when somebody's done the mean testing, they have to pay. They would sometimes think that it's the hospital demanding the money. That becomes, again, an issue, and that's why you'll see some people in the press saying that they came for a service to a particular place and they were told to pay. But actually, they were paying for the insurance. And actually, when you look at that, when they come to hospital, the first priority for us is to make sure that the patient pays for SHA, not paying for the service. Because when you pay for SHA, it means it's a earlier treatment, so that the next time they come with their families. You don't ask them again to go back to their pockets and look for money or pay.
Okay.
Yes.
And it's a good thing you've brought the issue of misinformation, because here there's more concerns that are coming our way. And Kenyans are saying, you know what, SHA is not working. What will happen with the pending bills? Another one is asking, I'm still in total confusion whether it is SHIF or SHA. And you can see there is clearly a disconnect.
Yeah, true.
How do we bridge that?
Yeah, so, yes, you can see from across the media, in the newspapers, in the social media, there is a lot that are said about this new kid on the block. A lot of it is misinformation, and you know, wrong news usually sells a lot more than the good news. However, from our space, we want to clearly tell Kenyans that we have a lot more good news with SHA. It's really going to be a game changer for everybody, for this country, and it's a target for everybody across the world. It's a WHO target. It is everybody who is in the health space, and to ensure that everybody gets access to health.
Okay.
Now, for us to really debunk this myth of misinformation, it is what we are doing, for example, today, that we are here, other people and other colleagues with the right information are in the various media houses to debunk and give the right story, give the right trajectory of exactly what SHA is and what is possible with SHA and what's not possible, and where the challenges are and where the solutions are. And that's why we are here to talk about it. And I think when we also bring in the media, including yourselves, to share the same stories and the good stories that we have, it will actually be bought by Kenyans over time.
Okay.
Yes.
Let's not talk about patients suffering from chronic diseases, because these are the patients that we've seen have most concerns and complaints in regards to this social health authority and SHIF in general. So, first of all, how much is allocated to each patient, and what happens if someone's cover is depleted?
So first, you know, there are various funds under SHA. The first one is SHIF, the Social Health Insurance Fund, which is equivalent to what was NHIF before. We have the ECCIF, that is the Emergency Chronic Disease Fund. And then we have the Acute Emergency Fund. Okay. So all this together with FIF for the low level facilities. And again, the design of SHA as a medical cover for all of us is such that it's supposed to be a referral system. It's a continuum of care from a lower level facility to the highest level where we some of us sit. And when we talk about the lower level, it means it's the primary care, or what we call actually primary care network across the country. And that is patients who are taken care of in level 2, 3, and some of the selected level 4s. Okay. And therefore, if you look at that, because prevention is better than cure. If I'm going to spend probably $1 million to treat somebody with maybe say cancer, if I prevent this by doing screening upstream before they get to the stage which is advanced, I would actually spend much less compared to when we wait for a patient to reach stage 4, and then now you're required to do chemotherapy, radiotherapy, you do probably even surgery, etc. So if we start preventing this from all the way upstream, it will actually make our healthcare cheaper. And therefore, we will not have the issues of saying that you're going to spend all your money treating yourself in level 6, level 5, and level 6 for various conditions. Yeah. And therefore, if you look at this, the various funds, so if a patient is referred for a specific reason to come to next level, which is a higher level, of course it will be slightly more costly. But when they were in the lower level, it was cheaper, and you are able to manage that patient more cheaply. And therefore, whatever is allocated for various conditions will actually be spent and spread appropriately. Okay. Healthcare becomes very expensive because we all wait to get to the advanced stages of disease. And that's why this design of SHA will actually sort out the patients when they still are in stages where it is still cheaper to manage. Okay, so what happens, for example, right now with the implementation of SHA and SHIF? What happens if
a patient walks into a level 5 or level 6 hospital instead of going all the way from level 1, 2, and 3 and follow that chain?
Yeah.
Do you take them or you return them?
For now, we still check all the patients because we are still at the implementation stage of the referral network system. And also, the very important aspect is that the counties and the other levels which are managed through the counties need a lot of support to really improve on the quality of service that they provide. And therefore, when you look at this, it's not something that can happen all over, at once, that you return everybody who comes to level 6 to go back to the counties. That's one. But number two is that there's an aspect where all emergencies, whatever kind of emergency that we get, irrespective whether the lower facilities were working or not, have to be treated. So if we have an emergency, somebody has gotten a road traffic accident, we will not ask them to go back to their counties. But I think as we implement the processes that are coming up with SHA, soon we'll have a proper referral mechanism to be able to send patients from the lower facilities to the highest level facilities.
With this new health authority, we expect an influx of patients. So then in this particular case, do we have adequate personnel in referral hospitals? And what happens in a deficit?
SHA actually has come to give us a solution. Because as it is now, a lot of patients come from across the regions where we operate from. These patients means they bypass the other levels of care and come to everybody wants to be treated at the referral hospitals. And when by the design of SHA itself, it means we're going to share some of the load. So there are patients who, for example, would come in with very simple and minor ailments, like a simple flu, a headache, just to go for a refill of their medication, like for diabetes or for hypertension. They would not need to come to the highest level of care, because those are things which they can continue. And the other aspect also, which is important, is that there's always a downward referral. Patients who have been taken care of and done surgery, for example, in level 6 hospital, can be referred back for routine care in the lower facilities. For example, just dressing of wounds, being given medication, checking their blood pressure, seeing that everything else is normal after the care. So it will actually reduce the pressure that we have at level 6 facilities, which has been immense for the last many years.
Okay, in 30 seconds, you say that SHA is an equalizer. For a Kenyan who does not understand how this will help us achieve the universal health coverage, in 30 seconds, maybe you can explain it.
Yeah, so thank you. Now, as I said again, UHC has been a desire across the world for everybody to have an equal opportunity to receive healthcare. And therefore, when the government of Kenya has now taken up this role to ensure that we have SHA, and and again with the various funds that have been created, it is intended and designed to support everybody, so that those people who are working can have whatever they pay what we would call equity, a percentage of what their earnings. So so if you're earning 10,000, you pay less, and you pay a percentage of that, 2.75%. If you're earning $1 million, you pay more, but it's a percentage of that 1 million. So that everybody pays an equal percentage of what is due to support the rest. And for those who are not able to pay completely, there is opportunity also. Those are the team called indigents. Is that there's a fund which will take care of them, so that everybody across in the country will actually receive health care.
All right. Of course, we'll continue having this conversation and giving Kenyans more information on the Social Health Authority. But thank you so much, Dr. Philip Kirwa, who is the CEO of Moi Teaching and Referral Hospital. We take a break. Up next is business.
From the